At Medical Service Company, we know that a properly fitted mask is key to a patient's long-term success with positive airway pressure therapy. With so many mask types, manufacturers, and models available, the process of finding the right one can be both time-consuming and overwhelming. That's why we're excited to introduce cutting-edge technology that streamlines this process and significantly reduces refit rates. By using advanced scanning tools, we ensure a more precise and unbiased fit, giving patients a better chance to succeed in their therapy. While the national average refit rate sits at 25%, our technology has allowed us to lower it to under 5%. This means fewer adjustments, more comfort, and better therapy adherence for our patients. To learn more about mask fitting process or our innovative technology, reach out to our local MSC territory representative or visit us at www.medicalserviceco.com.
The next lecture in our sleep track is titled Top 5 Tips for Managing Patient Challenges from CPAP to Advanced Modes and is being presented by Tammy Muth-Davis. Tammy has been a clinical specialist with ResMed since 2015 with prior experience in all facets of healthcare, from CEO to staff therapist. Her experience includes managing an AASM-accredited sleep facility, overseeing the respiratory care, pulmonary rehab, cardiac rehab, and cardiology departments, as well as clinical care management for respiratory services in long-term care settings. She is a registered respiratory therapist with 44 years of experience, registered polysomnographic technologist with 25 years of experience, plus holds a bachelor's degree in business administration and is a clinical sleep educator. Her primary focus is educating providers, therapists, nurses, sleep technologists, and home care providers on advanced sleep therapies and improving patient outcomes. She is committed to driving new pathway development and sharing clinical knowledge with colleagues to improve patient outcomes through collaborative information exchange and discussion. Tammy also currently serves on the AAST Education Advisory Committee. In her free time, she enjoys reading, biking, paddleboarding, cooking, camping, and planning events for friends. She resides in Georgetown, Tennessee with her husband, Stephen, Go Volunteers, and her loving doggie, Ralphie, and enjoys spending time with her children and grandchildren. Thank you, Tammy, for your participation in today's forum. Tammy will be taking questions following the conclusion of her lecture. Please submit your questions using the Engage tab. Don't forget to submit your evaluation of the lecture. Bon appetit!
Good morning. Thank you for joining our conference for today. My name is Tammy Muth-Davis, and I will be speaking with you on the top tips for managing your patient challenges from CPAP to advanced modes. Some of our objectives today will be to review that patient journey and understand where our challenges are and to look at where those gaps and that barrier to identify where that we can be successful. We also want to be able to assess and set our patient therapy goals with using enhancing engagement, encouraging our patients to really engage with their therapy. Also looking at how we can further assess where that patient journey as along their way happens to. We want to be able to look at how we can optimize those telemonitoring tools and really look at those Medicare guidelines if we're having trouble understanding where our patients transition. So our goal is to make sure that we're managing our therapy throughout their journey, helping them through those challenges and the barriers that they may meet, and making them understand the right therapy for the right patient at the right time. So when we start to think about our tip number 1, understanding our patient journey and those barriers that begin from diagnosis to treatment. When we look at patients, we understand that 28% of our patients are diagnosed with OSA, but they never receive their PAP therapy. That's very concerning to me. We also want to look at what is the average time gap between sleep tests and getting CPAP. Patients receive their sleep tests, and the average time for setup throughout the United States is around 78 days. Now, continue to think about that if you're that patient. We also know that 11% of patients who receive a prescription do not move forward with their PAP setup appointments. So if we look at these statistics, we understand that already from the beginning of the patient's encounter with their diagnosis of OSA, they're running into barriers already. our goal is to understand how we can assess those barriers and help our patient move through that journey. So as we think about this, we want to talk about our patient, Robert. Robert is a 52-year-old male, and he came in for his initial sleep consult. He had no witnessed apnea. He completed his apnea, his Epworth sleepiness score. He denied being sleepy. He said that he did not wake up gasping for breath. He does work swing shift at a distribution center. When we review his objective data, he's married with 2 children, high school age. He does have some history of back pain for which he takes some oxycodone pain medication. And he does have seasonal allergies. Doesn't smoke, but he has 2 to 4 beverages on the weekends or when he's off. No history of heart disease, no hypertension, but he is a little overweight and he recently started a GLP-1 medication for weight management. When we complete his assessment, his Epworth sleepiness score shows that he has an Epworth score of 12 with a stop bang of 6. He has morbid obesity with a BMI of 41 and a neck circumference of 22 inches. His results are a strong suggestion for moderate to severe OSA. He does have some occasional insomnia and does take some over-the-counter medications. So the physician has planned for this patient to receive a home sleep test and follow up with him after his test results. This is at times our typical patient, and this is the journey that patient ends up following with that home sleep test. So for us, let's look at where we're at. Tip number 2, there are barriers that we already can see in Robert's journey. There is that communication of consistency among our providers, understanding that when we look at these patient challenges, one of the greatest things that patients state that their challenge for long-term therapy encounters is in their education. What are the expectations of their journey? What's the assessment? What's their diagnosis and treatment? So at the very beginning, Robert is already at a deficit to understand that it may take a time period for him to receive that home sleep test. What sort of education is Robert going to receive when he gets his sleep test? Does he understand what the next steps are for following up with his provider? And then does he understand that the long-term journey may include PAP therapy? It is very important that our patients understand this relationship from the beginning. And not only do they understand it from the beginning, that they coordinate the care, that we as providers are helping to coordinate that care. If you are part of the physician's office, if you are the sleep technologist that's going to be giving them the sleep test, if you're the therapist that's setting up with their PAP, making sure that we're all using the same language, that we're establishing for Robert what that coordination of care should look like and what will his journey be. And that he understands that he will receive ongoing support, that we understand that what is the process if my mask is an issue, because we also know that mask comfort and mask leak happen to be issues for that patient. And again, we're confirming for them that relationship with PAP is a lifelong, long-term journey, but is one that will impact their life overall. And also having some instances, depending upon where patients are at in their financial perspective, what is that cost of care to them? That is a barrier for some patients and in terms of continuing their care throughout their journey. So tip number 3, let's talk about what a typical patient journey looks like when we put this practice actually into action. We know that, first of all, we should really look at what is that patient's phenotype. What is it that we should expect about them? We have studies that show that patients have a preconceived idea of what their PAP journey will look like, what a mask will feel like before they ever even get a mask. And that journey and that perception can come from their family members, from their friends, from social media, from television. And we have to understand that all of these will impact what our patient's journey is like. We need to be able to assess what support that patient has within their home and what support are we going to be able to provide them. Making sure, again, that our education is consistent. What is OSA? How many times have you had a patient come to you and say, I don't even know why I'm here? Think about that. If that patient doesn't understand why they're here, what do you think their likelihood of adherence with therapy is going to be? We want to make sure that they understand what is the timeline that we're expecting for their therapy and what, most importantly, is the impact to their comorbidities of their health. Robert already has hypertension. What is that long-term, and he's already overweight? What is the long-term impact to him? He doesn't have cardiovascular disease now, but what does that look like if he doesn't treat his obstructed sleep apnea? We also need to understand who's going over those results. What is that PSG, that home sleep test? What's the date for it? What does he expect in terms of when he will receive? How is he going to put that therapy on? Patients are now receiving SHIP-2 home sleep tests with minimal instruction. They may have never even encountered a therapist as they're getting their home sleep test. So what instruction are they getting? What are they getting to support their journey? Who is making sure that sleep is being explained to them? What is that arousal index and actigraphy? Do they understand what that means, how it impacts their sleep continuity and their overall health and well-being? And are we understanding that prescription for optimal therapy? And how are we making that decision about the optimal mask? And again, you're going to hear this same theme throughout: education. How are we educating our patients? And then our third aspect, again, is education around their mask, proper fit. Remember, we may fit it and we may instruct them as they're in our office or as they're in the sleep center, and they've consumed so much information that they are going to forget throughout the night. What do they have to support them at 10 o'clock at night when they're putting on their mask and you're not available? How can we help them to understand how to refit and place their mask appropriately? What remote monitoring tools are you using to assess what Robert's journey is? Again, we know from studies that as early as day 3, we can predict if someone's going to be long-term adherent. If they're struggling, what's that early intervention going to look like? Does the office that he's been sent to for that sleep provider have an APN or a PA that's going to follow up? Is there a patient liaison? What does it look like within your DME world of who is following up and monitoring that patient? And again, how are we using those remote monitoring tools and the tools that are built in to help us to assess? Again, it is key in this tip number 3 that we really identify what is the right therapy early in the process and what are the steps for Robert to keep him adherent with therapy. Now let's look at Robert. He's had his home sleep test. Let's understand exactly where he is. So he was referred to the sleep center. The initial contact took about 2 weeks to coordinate care because remember, Robert works kind of a swing shift. So he received a sleep test. It was shipped to him with instructions, but he didn't wear the device for 3 nights. The device was mailed back to the sleep center. When it was sent back, his data was suboptimal. So now they had to repeat that contact to Robert. It took additional 6 days to contact him. There was a delay of 2 days to complete the sleep test to get it mailed out to him. And 3 days later, he did wear it. This time, the device came back and his test results were optimal. They were downloaded and the results were interpreted. When they looked at Robert's results, he was scheduled at 4 weeks after his home sleep test to follow up with his provider. Results showed that he had moderate OSA with an AHI of 21, an AI of 11.4 with a CAI of 4.7, and a HI of 10.1. His snore was severe, and he did desat to 85% for 10 minutes of his total sleep test. So the physician's plan was to order APAP at 4 to 15, mask to patient comfort, add the patient into the provider portal for AirView, and engage them to educate on the Meyer app and to their care check-in responses. And they were scheduled again for that 8-week follow-up with the physician. So he's going to wear his PAP for 8 weeks before he has that follow-up. So let's talk a little bit about MyAir or patient engagement tools. There are other patient engagement tools that are out there, and we need to make sure that we're giving the patients all of the support that they can receive. Any app that's going to help them work through understanding what their process is, engaging with their own care is vitally important. We again know that patient engagement tools help to improve our patients' overall adherence and education. And this is tip 4. Engaging your patient in their care. It doesn't matter what tool you use, it matters that your patient is engaged and has access to resources to understand what their journey is and where their challenges may be and how they can seek help. When we're using within the MyAir app, there's a dashboard for that patient that displays how many hours that they can use the therapy throughout the night. They are also able to set goals for themselves and note if those goals are not met within that 30-day period. Remember, we talked about reinforcement, engagement, patient-family engagement as well. Having that patient to set goals for themselves will also help them to proceed along that long-term patient journey. Their goals, if not met within that first 30-day period, can be reset to the next 30 days. So we're working diligently to get Robert to that 90-day adherence and that long-term, life-term journey. Each time that he succeeds, he's getting little badges. But if he doesn't, he's getting push notifications that let him know, I need to work on this, or great job, great milestone that you've achieved, to continue to provide that support. And in that achievement section, it allows them to see what they've earned so that they can continue to work through. So Robert's app would look like this. Each day, he will get a report to understand where he's at in his journey. He will get tools that allow him to understand what he's achieved to work toward that long-term adherence. If he is struggling, he'll also get educational videos that are going to help him to understand maybe where his challenges are to continue to work toward that adherence. The smart coaching aspect of this, again, as we were talking about those tools, is that timed messages will be sent for him to receive a series of messages around education that may address his common challenges, and even based upon his events. He'll get event-based messages based upon his intended and his reported events that he's having to encourage and motivate him for consistent use. If he's having trouble with his mask, or he's having trouble getting used to therapy from humidification, all of these factors will play in and give Robert coaching along that pathway of where he seems to struggle with therapy. How that personalized coaching works is that at day 1 through 7, he'll get content that matches what his therapy dashboard is. So where he reports that he's struggling and what his therapy dashboard looks like, he will receive coaching that matches those values. If he's still having apnea, it's going to give him information around where that is. It will make recommendations to him to help him support that increased nightly usage. And it's important to note that he'll continue to receive, after those first 7 days, classic coaching messages. Those messages don't go away. They continue to support. So now on the HME-DME side, how are we looking at what's happening for Robert? It really is important that you have a good follow-up plan within your process. Robert's received his device. We need to know where he is at and how he's doing. And again, early in his stage, from day 1 to 7, has a 95% prediction of where they will be from adherence at day 90. So we really want to look at where we're at. So who within your HME is looking at this data? How are you pulling and evaluating within that first week, that first 30 days of therapy? So tip number 5 is that you have a well-defined action plan and follow-up for your patients, making sure that they have access to the tools that are available, and you're optimizing everything at hand for you. As we can see, we're looking here at Robert. He's at day 16. He's 27% adherent. Part of that's because he's at day 16. The first 4 days he did well, but he has struggled to meet that adherence in these last 5 days of therapy. When we put and scroll on his night, we can see that his usage is at 3.03 hours. His leak is controlled, but his AHI is still elevated. What should we be looking at to control for Robert? So also in context of what your AirView data is, you want to encourage, remember the physician prescribed for you to speak to Robert about Care Check-In. Care Check-In is a tool that's going to ask Robert questions at day 1, 3, 7, 14, 21, and 28 about how he is doing with therapy. It asks, how's your mask? How's therapy going? What's uncomfortable for you? How sleepy are you? And based on Robert's results is where part of that personalized coaching comes from. But understand that you as a care provider can also see Robert's Care Check-In. So our last screen was that big view. But when you drill down to Robert, you're going to be able to look to see that Robert answered his Care Check-In questions, and understand from there, when you look into his therapy data, you will be able to see that his last few days of therapy, that he has answered those care responses. This helps us to understand where his challenges really drill down to. So looking at this in a closer view, On 8/12, Robert said that he was still extremely sleepy. We see at 8/14, he answered his questions again. And now at this, his therapy's okay, but his device is really what's bothering him most, and it's the hose and the tubing. So again, we're looking throughout. We see that he's still slightly extremely sleepy. So he's continuing to be sleepy. His therapy's going okay, but he's still struggling with the device. And primarily, he says it's either the hose and tubing or adjusting to the PAP therapy. So as we drill down further and we look at Robert's case, we really want to look at where he's at and looking at his download information. But by looking at this, we need to understand, where are we at with Robert? What is the most important thing? Robert may be at that point where we need to consider another therapy for him. He's struggling still with therapy. He's still sleepy at day 30, and he's not wearing his therapy all the way through. He's struggling to use it throughout. So we know that we can identify steps if a patient needs to transition to another mode of therapy. At these certain points, we can either transition them at diagnosis, at titration time, at therapy setup, throughout that therapy manage, and that's where we are at this point, throughout that therapy management for Robert. We want to make sure that we're understanding, is APAP the right device for him? Are his pressure ranges at the right ranges, or would he be better benefited with another mode of therapy? So let's take a look at his detailed case report. When we look at his detailed case report, we see that he's struggling to use, but his usage has not met our adherence criteria. He's at 70% of the nights is what's required in order for Medicare to pay for his device, or for his insurance to cover for his device. We know that his care check-in response indicate that he's still struggling with the device, and he is still extremely sleepy. When we look at his pressure settings, we've already put in place comfort features with that EPR of 3, and his patient pressure settings are at 4 to 15. When we dig in and look at his leak is well controlled at less than 24 liters per minute, and he's not complained that the mask was his issue. So his mask leak is controlled, and mask seems not to be his problem. When we evaluate his AHI, we can see that his total overall AHI is 6.1. 5.8 of those events are, I think that's correct. 6.1 is his overall, 5.9, sorry. 5.9 is his overall AHI, with 5.8 of them being hypopnea, 0.1 of them being apnea. So he does still have a slightly elevated AHI, and they are primarily noted to be hypopneic events, and his mask leak is controlled. So do we consider that he is on EPR of 3, so we're already lowering his pressure for him to be acclimated, or do we make that transition to a conversation with our provider to say, do you think with his obese weight that he may benefit more from a bi-level therapy? Because maybe the issue is he's not feeling that he's getting enough to offload where he's at in terms of his inspiratory effort. Or do we look at maybe turning off expiratory pressure relief and then evaluating for a period? In Robert's case, let's see what that provider made the choice to do. Well, first, let's talk about the impact of mask. So as we look at the impact of choosing the right mask, which it appears for Robert that he is on a good mask for him, we want to make sure that that mask is comfortable, and understanding that if it's not, remember, you have that first 30 days where you can change that mask to give that patient comfort. But I want to challenge you to say, in your time period with a patient, how often has changing the mask resolved the issue, especially when you change more than 3 times? The more times that we change the mask, the more options that we give our patient for mask, sometimes the more that it can lead to disruption for our patient, because they don't know what's best for them. They know what they think they want, but as clinicians, we really need to, before we even make an offering, understand, how does our patient sleep? What does their lifestyle look like? What is most important to them? Meaning, how do they sleep? Do they toss and turn? Do they get tumbled in their pillows and blankets? I mean, are they all over the bed? What sort of mask do we need for that type of patient? Is it important to that patient that they can't stand very weighty on their on their face, a weighty mask on their face? Because for them, it makes them feel even claustrophobic, or it's just very disruptive. Do we need to understand, is this somebody who has health issues that has very fragile skin? Do they like to sit up and read at night? What's most important to this patient? We need to make that determination from an assessment and conversation with our patient, not just saying, do you breathe through your mouth or do you breathe through your nose? There are so many more options for our patients out now that breathing through your mouth and breathing through your nose doesn't dictate the best option for the patient. So really dig in and understand how your patient sleeps, what's important to them. Are there health issues that are going to impact? If they have claustrophobia, do they want something that's lightweight? Understanding where they're at in their patient journey. Now we can drill down on a pool of masks that would be optimal for our patient, eliminate some of those options that they might have, and say, I think one of these two masks might be the best option for you. Let's start here instead of saying, here's a wall of 50 masks, pick which one you want. Does that resonate? I hope that resonates with you as clinicians. We need to make sure that they're adapting well to their mask before we ever consider any change to therapy. I want to emphasize that one more time. When I get asked to come in to consult on a patient's download, 85% of the time, the issue is mask leak. If we're not addressing that for our patients and making sure that we've made that the primary function that we fix, then we're not really doing service well to our patients. So we want to make sure that we've got the right mask and that we're selecting the mask that seems equally beneficial, as we've stated, for that patient's sleep type, for what's important to them and to their overall health. So Robert now, as we talked to the physician and we've made that follow-up to him and we've qualified that he's did meet that Medicare guideline for qualifying for PAP therapy with an AHI greater than 5. We've also looked for Medicare guidelines that we've stated that his mask has never been his issue. It's not been a leak. Mask has not been a challenge for him. But we do note that he's still having symptoms and his current therapy is not treating him adequately. He's still extremely sleepy and we still have a mildly elevated AHI. So we reviewed his report. His mask leak was controlled at less than 24. His AHI overall is 5.9. He's attempting to use at least 4 hours per night. In his data, when we look at his data in AirView, we note that at times his respiratory rate is elevated as high as 24. We're seeing a cyclic increase to his respiratory rate, and we're seeing that his tidal volumes at time are dropping to 285. When we dig into his detailed report, looking at that tidal volume and respiratory rate in values. So Robert seems to have periods where he may actually be not only having airway hypopnea, but lung hypoventilation. So the assessment was made. The physician agreed that this patient might benefit from some bilevel therapy. They made that adequate documentation and they didn't have to see the physician again face to face. Remember, because we're in that first 60-day window. So you're waiting for the order to come from the provider to transition Robert over to bilevel. We did just recover and review those Medicare guidelines, but let's review them one more time. This is what needs to be documented in order for Robert to receive that therapy. The provider can simply write that note. They don't have to see him for a face-to-face, but what they need to document is that his issues were addressed during titration or home use of an E0461, which is that CPAP, APAP. That those issues that we talked about is that he did qualify and that we looked at these two factors, that he's been properly fitted with his mask and his mask is not an issue, documentation here, and that he's got factors that are preventing his therapy tolerance. A lower pressure was tried because he's using expiratory pressure relief, but he's still not seeing adequate control of his symptoms with an elevated AHI of 5.9. He's not seeing improvement in his sleep. He's still very extremely sleepy, and his reduction in AHI is not to that acceptable level of 5. However, I would argue that 5.9 was a good level, just to state that. So Robert's received his bilevel order. The physician's given you the therapy documentation. His provider was ordered bilevel Viato at an EPAP of 5, a max IPAP of 20, and a pressure support of 6. He's using his current mask and he's still using AirView, and he's going to get those care check-in questions again at those throughout that 30-day period, 1, 3, 7, 14, 21, and 28. He's to follow up with his provider in 5 weeks. So we look at his data and we see, remember, you can make changes to your patient as you're reviewing them throughout their data period. You also have the access to make remote changes to his bi-level settings should he need any changes in your cloud for therapy. And you can also see what is happening with that device throughout that time. As we look through this therapy data, we see that Robert is improving, but we also want to look at what can we do to lead to success with his PAP. Following the American Academy of Sleep Medicine guidelines, we know that PAP initiated using APAP at home or CPAP for a titration with OSA and no comorbidities is appropriate. We know that CPAP or APAP over bi-level is that routine treatment. We want to begin with CPAP or APAP, looking at and assessing when is that right point if a patient moves to bi-level. We also know that bi-level for OSA may be needed for patients who require pressures that are greater. It may be a decision to change to bi-level. Really depends on the individual needs of each patient. And what are the factors that we review when we're considering that PSG and reported patient outcomes? We need to understand that we're looking at improvement in that patient overall and what are we using to make decisions. I feel like that as you're titrating, if you happen to be a night technologist, there are 6 things that I think if you can document that will help your provider, it will help your HME, your DME partner to make the right decision for that patient to progress if they need another mode of therapy. And the 6 things that I think you should document every time you make a pressure change or at your 30-minute check. And not only do I think this, but if you look through Dr. Berry's guidelines, and if you look through the guidelines for titration, they're saying these other 6 things are also important. Number 1 is your mask leak. Number 2 is your heart rate, your respiratory rate, hold on, my brain just had a moment. Heart rate, respiratory rate, tidal volume, SpO2, heart rate, respiratory rate, tidal volume. Heart rate, respiratory rate, tidal volume, SpO2, mask leak, and if you have availability, your CO2, your transcutaneous or end-tidal CO2. So let's go through those one more time because my head got confused. So we want to document heart rate, respiratory rate, SpO2, tidal volume, mask leak, TCO2, end-tidal CO2 if you have it. Tidal volume is one that I am certain that you may or may not be recording throughout your PSG, but when you are titrating, no matter the device that you're using for titration, you have access to that tidal volume reporting. That is another tool that will give your physician and your HME information that will allow them to support documentation for that payer in order to get approval for your patient to go on the right therapy. We also know that adherence patterns for therapy improve or change over time. We also know that education, and I can't say that enough, education is the key to supporting and achieving PAP adherence and long-term therapy goals, and making sure that your patient knows who is educating them, where can they go for help and assistance, what is their priority guidelines of who they reach. Call this person first, this person second, this person third. So they understand what is the pathway that they can reach out to get assistance. Okay. That is very important. Is it the sleep tech that they can reach out to? The physician? Do they have someone dedicated in that physician office that that patient can call and ask for assistance from? Is it a sleep educator that they have? Someone that's got a CCHS that they're asking to come? Is there someone within the healthcare system? Or is it their DME? And who at their DME is the partner that they should be reaching to? What's the right number for them to call to make sure they can get assistance? So also understanding that when we talk about monitoring in DME, that we know by using these monitoring, these telehealth features, that we improve. This is a study that was looked at by Dr. Wooler in 2024. It was a retrospective analysis of patients that are long-term PAP therapy, looking at their termination rates versus standard care, meaning all they did was have the DME, look at that download when they came into the doctor's office, or the doctor only looked at it when they came into the office, or they used a proactive approach to using that data that is reported every day and loaded into the cloud. Again, whatever device you're using, making sure you're looking at it is the most important thing. Looking at those guided and proactively responding to that data that they see in the cloud, and that patient understands the importance of what's reported on their patient engagement tool. So when we looked at this, there were 104,612 patients that looked at them with an average age of 61. 71% of these patients were male, and the mean follow-up was 3.3 years. What they found is that when they used AirView only, that their adherence and compliance, their rate with standard care, meaning we didn't use AirView, was 27%. These patients fell off. When they used the telemonitoring only 20% of these patients fell off. But when they used the telemonitoring plus the patient engagement tool, only 11% of these patients fell off therapy long-term at 3.3 years. So if you think about that every year you're losing 20% of your patients that are on therapy, by the year 5, when they can qualify for a new device, or where we impact their long-term health, where we really make a difference in that patient's long-term health journey, 100% of your patients are off therapy. So consider adding and encouraging your patients to utilize patient engagement tools to be engaged in their care and to improve their adherence for long-term patient care and therapy. So Robert is who we've been talking about. So let's see where Robert ended up. His care check-in responses improved. His daytime sleepiness improved. He wasn't having a problem with the device. There was no problem with the mask. And guess what? Robert's insomnia even got better. He's falling asleep sooner, easier with therapy. His AHI was controlled at 2.9 events. He has had some weight loss, but not significant, because he had to stop his GLP-1 medication due to the cost to him. So his PCP did send him for follow-up because they are still concerned about his weight, with a nutritionist to look at ways that they could help to improve his diet and some of his activity. So the physician's plan is continue with that therapy and follow up at 3 months. And the DME was going to continue that close observation for that for that time period until we're certain that Robert's on a good trajectory and a good path. And they're really going to look at resupply, because resupply is another reason that patients stop therapy, because they think their mask is not leaking. It's getting those little micro leaks, and they think their mask looks good. And guess what? Micro leaks lead to micro arousals that patients are unaware of. Micro arousals lead to fragmented sleep. Fragmented sleep leads to daytime sleepiness, leads to the patient not wearing their device 1 night, 2 nights, saying, I don't feel any different. So guess what? They stop using therapy. We need to make sure that they understand the importance of that journey, that they need to understand the importance of resupply, and that we're encouraging them to do that we're alerting them to that, and they're using those correct tools to stay healthy, and that we're encouraging that proper diet and exercise for Robert, because we want to make sure that we're addressing also his weight loss in that relationship and journey. So remember, as we talked about Robert, one of the main things that we've hit on is that we identified that he needed bi-level therapy from that telemonitoring aspect and the information that he provided. So let's look and see at some of the studies that support this telemonitoring. This is our tip number 5 tie-in again, the benefits of that remote telemonitoring. We have 3 studies that are well validated in the Journal of Clinical Sleep Medicine that look at outcomes and benefits of telemonitoring remotely. And remember, if you don't have a good process that's well defined for you, if you don't understand who's following up with your patients, who's making and responsible for this, I encourage you all to go back to the organization where you were to say, how are we doing this? What is our process and plan to make sure you understand what your role is in that patient's journey? But let's see what Dr. Champagne says as well. He says that the use of telemonitoring systems can help CPAP nightly usage hours significantly improve therapy adherence and sleep quality with patients that have moderate to severe OSA. When we look at what Dr. Pepin says, he says that telemonitoring also allows us for intervention in cases where the emergence or the persistence of respiratory events jeopardize optimal use of PAP therapy. Now, let's think about that one for just one moment. We know that we have patients that present to us with either treatment emergent central sleep apnea or they have persistence. They may have had central apnea in their PSG study, but the physician chose to be very conservative and not make that choice to move to therapy. Using that telemonitoring is really going to give us insight into where we are. Has that treatment emergent central sleep apnea resolved itself, or is it still persisting? Is it getting worse? These are things that can really help your patient to understand where they're at and not jeopardize that we're under treating and getting them on the optimal right therapy for that patient. And lastly, let's understand what Dr. Malhotra says to us. He says that by adopting advances in technology and care management, we may allow the clinician, that's you, to more efficiently and effectively treat patients who have sleep apnea. What does that mean to your daily world if you have an improvement in your efficiency and your efficacy of how you're treating your patient? That means you have more time in your day. And I would venture to say that if I queried you all, that the last thing you would say that you had was time to take on a new task. I'm asking you to consider a new workflow that improves your efficiency and improves your time management. So please, as you're considering that, take that into mindset. This is not only going to improve your life, but it's going to improve your patient's life. And lastly, let's look at, or not lastly, we have one more slide after this. Let's look at tip 6, which we did not allow for a tip 6, but there is an important tip that we need to consider for our patients, and that is mask resupply. We know from a retrospective analysis of 100,370 patients that they showed reasonable resupply of mask interfaces was associated with a statistically significant increase in their average PAP usage. So patients that had good resupply slept 5.6 hours per night. Patients that did not have resupply slept at 4.5 hours per night. Their lower rates of therapy usage also led to an increased termination if they did not have good resupply. So those with a good resupply program were less likely to terminate versus those at 14.7% versus those with no resupply program at 31.9%. So again, as we discussed earlier, this means that if your patient has no resupply program, that they are not going to maintain PAP therapy long term. And that is the most important aspect that we should be considering. Because again, resupply, when we think about it, patients have a little small leak in their mask and they say, oh, it's good because they look at it and it looks fine, right? Looks good, no tears, no rips. But they don't know or note those micro leaks. Those micro leaks lead to that micro arousal. That micro arousal leads to poor sleep consolidation. Poor sleep consolidation means we're not getting delta sleep. It means we're not transitioning necessarily to the amount of REM sleep that we need, which then means we're daytime sleepy. If we're sleepy and we're wearing our CPAP, and we may start to snore and our bed partner starts to complain because our mask is leaking, we're snoring, what's going to happen? They go on vacation, they leave their CPAP at home, 1 night, 2 nights, 3 nights. I don't feel any difference in how I am with therapy or without therapy. So what do you think that patient's going to do? They're going to stop using therapy. Resupply is vitally important. Again, I challenge you to understand what is your resupply program. How are you making sure that patients get the resupply that they need? Are you making them aware of the importance of resupply? Are you encouraging them with an alert? What does that look like for your patient? Do they understand how important it is in their journey? And now, lastly, our last slide really looks at that patient engagement using that technology to improve their adherence with PAP. So technology, as we've talked about with multiple levels, patient engagement tools, patient goals, care check-in, setting the expectation and educating the patient, all the way from the provider to the sleep test, to the sleep technologist, to the HME. All of us need to have the same message for our patient. We all need to understand what that journey looks like and what part we all play. And now let's understand in this last study from Dr. Malhotra what we looked at. He looked at a retrospective analysis of 128,037 patients who were being actively managed using the cloud-based technology for patient monitoring. What they found is that patients who engaged within 7 days of therapy start date with the usual care monitoring is what they were comparing against. So what they looked at is that patient who had active engagement versus that patient with usual care. There was an 83.3% adherence in those patients who had an active patient engagement and an active patient monitoring program versus those who received the usual care model, which is we'll get a download from you when you come in. We'll look at it when we're there. Someone who's not really looking at and actively monitoring that patient. They also found that the average nightly usage, 5.9 hours versus that usual care usage of 4.9. And patients who were struggling, 17.6% of those patients who used this patient engagement and the monitoring tool had an absolute improvement in their adherence using that engagement tool. 17.6% had an absolute improvement. That means they stayed on therapy, they felt better, their leak was controlled, they were able to fit their mask. And guess what? If they know how to put their mask on and it's comfortable for them, they're not coming back to you for a mask refit. They're not coming back to you for a new mask. How does that impact your workflow in your day? How does that impact the patient calls that you receive? So giving the patient those tools to help self-solve, to engage with their own care is really not only going to impact your patient, which is our number one goal, but it's going to impact you and it's going to impact your physician. Because guess what? Your provider knows you do a great job and they have confidence in what you're asking when you call to reach out to them. This is not just about Robert. This is about every patient that you treat. So I ask you to really consider all of these things that we've talked about with these 5 tips. Improving that patient engagement. Sorry, we had 6 with resupply. Making sure that we lead to those robust adherence rates that Dr. Malhotra said that they achieve by adding that modern technology that is there, changing the way that we look at our workflow, and really helping us to become more effective and more efficient in managing our OSA patients with that patient management journey. I appreciate so much your time. I hope that you've taken one nugget away. And I really look forward to our question and answer session.
Good afternoon. My name is Brent Mayberger, Director of Partnerships at Medical Service Company. Tammy, thank you so much for sharing your knowledge and expertise. And let's jump into the Q&A. Our first question here, Tammy, is how can we as sleep support staff help to promote patient engagement in therapy? We have a lot of patients, like you mentioned, that come in saying things like, I don't know why I'm here, or my wife told me to come.
So in my experience, I think the best way to facilitate that is to have good, open conversations, making sure that all of the parties that are involved in that patient care, that we're communicating the same features, the same information, and not leaving that information just to the sleep technologist or the DME company once that patient comes in. Really asking our physicians to have that conversation with that patient at that front end, talking about how important it is to use some of these engagement tools, how important it is for monitoring and establishing up front what is that guideline. Again, I think one of the things that we really emphasized is that patient education. And if we don't have that collaboration, reach out, search to. Physicians really want to be very collaborative as well. And not just collaborating with our physicians, but understanding, is there a point person within their office that we can reach out to that's leading that conversation, and that they have the tools to be able to share information appropriately with the patient. I think one of the reasons we see fall off is because we just don't establish that good conversation with our patients up front. So educating through the same continuum all the way through, really encouraging if you have that CCHS or that person that's going to be that either that clinical liaison as an RT or as a sleep technologist, And again, making sure that we're all communicating the same information throughout.
Thank you so much, Tammy.
You're
You
welcome.
mentioned micro leaks and the importance of resupply. I've noticed that often patients don't want to pay for supplies at the recommended frequency and don't understand the necessity of changing supplies. What is the best way to reinforce replacement?
So I think one of the best ways to reinforce it, of course, is if we're using a patient engagement app, that app gives them a score, right? Gives them that little face and says, hey, your mask is leaking. Even if they're seeing those micro leaks, or if they have a smart technology like a watch and they're seeing that their sleep is now less, I'm getting less delta or I'm getting less REM and I'm more fragmented with my sleep. I'm not feeling as well, making them understand up front that really the mask interface can be what's leading to that. They can see if there's a trend up on their leak, knowing that if they're not using the smart app, it shows on their device, just getting them prepared to understand, to know what they're seeing, and to really have that good insight, how that impacts their ability not to continue to have that little buildup of not sleeping well, not feeling the same. Because I always try to level set with patients that you didn't come to sleep just because you woke up one morning with a backache or you woke up one morning feeling bad. Sleep is a cumulative effect, or the sleep deficit is a cumulative effect. And the same thing happens if we're having micro arousals. So they have to be prepared to pay attention to what does their leak look like. If I have a sleep tracker, is my sleep changing? Oh gosh, it might be time for me to change my mask.
Thank you, Tammy. Some patients struggle with insurance limitations when it comes to resupply. What does ResMed do to help promote the importance of resupply to insurance companies?
So that's a great question, because we have an entire advocacy group or division within our company that constantly is looking at going to the Hill, going to the insurance organizations, supporting the importance of this with long term studies, continuing to look at even the benefits of wearing a device for 1 hour. We know that for every hour of use, from a study that was done in 2018, I think, from Dr. Doug Kirsch, we looked at, or Dr. Kirsch looked at, that efficacy of patients, that for every hour that they increased use, they reduced total health care spend by like 15% by not seeing their physician as often, not going to the emergency room, not having that impact of those readmissions. And these were healthy patients as well. We're talking OSA only, not OSA and respiratory failure patients. But knowing that for every hour they increase utilization, they reduce that total overall healthcare spend. So I think we advocate for that as ResMed constantly, again, with our medical affairs team that's going in and advocating to both payers and the Congress, to make sure we're helping to put those laws best in place. We also work with AA Home Care. Sorry. Yeah.
Thank you, Tammy. One of the attendees recently had a patient who was originally on pressure of 7 with his AirSense 10, wasn't feeling rested after years of being on it, needed a new machine as well. He scored an 11 and was put into auto pressure. Their new normal is a pressure of 11 to 13, and they feel it's been helping. The only issue, the mask they have loved is now hurting their nose with the higher pressure because they have to tighten it. Any advice on how to help with that, Tammy?
So I would think that there are newer. I'm not certain what mask that they're on, but I know that from a technology perspective, masks are always getting better. Maybe if it was pillows that they're using, they may want to look at some of the new advances in pillows that have been introduced recently, or even maybe a nasal cradle if it's the pillow that's hurting their tip of their nose, or the opening of their nose, looking at that nasal passage and just looking. I think constantly we see new masks being introduced. Not to speak about ResMed, but we have just recently launched a revolutionary mask that's got the fabric that actually fits up under the nose for a nasal cradle mask. And maybe that may be an option where they're not having to utilize, tightening the mask in order for it to seal. Then I would also ask is, when was the last time they changed their mask seal as
Hmm.
well? Because typically that's when you start to see that you have to change, or is it even their headgear? Is their headgear stretched out? So hopefully that was helpful.
Absolutely. Thanks so much, Tammy. And then lastly, where can someone find more case studies like the ones you referenced in the presentation?
So I do a web search. I mean, we of course have a medical journal site that we use within ResMed. But just looking at your prescribing or signing yourself up for either the AAST, the AASM. I know it's a little pricey for the AASM, but then you get access to all of those journal articles. But signing up also for things like Medscape that gives you like new literature. Another that I really enjoy and helps me to improve my overall knowledge is really CME Outfitter, which is designed more for physicians, but it really does keep you up with the current literature journal articles. And then I also would sign up for the Blue Journal. Oh, darn it. The AASM, of course, you want to get those, but the New England Journal of Medicine, you can sign up where they're going to just give you that alert and you can see that little blurb of what's new out there. And that does take time, but you kind of have to weed through and filter to see what is, most impactful to us. But really, I think those are one of the things that we can do that are really help us to keep at the edge of what's happening from a clinical knowledge perspective.
Tammy, thank you so much for joining us.
Thank you.
We wish you and your family a safe and happy holiday season. Today's session presentations will be uploaded to the FeedLoop virtual event platform and available later today for your convenience. If you missed the survey pop-up, you can access it this afternoon where it will appear for a short 2-minute delay. For any questions, please contact jsmceu@medicalservicecode.com. Thank you so much, Tammy.
Thank you. And same to everyone on the call. I hope that your family has a blessed, wonderful holiday season. So thank you all.
Take care.